Hello, everyone, and welcome to hopefully your last session of today. My name's Kathleen Graham. I'm a senior project manager here at the RCSLT and an adult speech and language therapist by background. So this session is called Back to Our Roots, the central role of communication in adult speech and language therapy. Some housekeeping, you'll all be well used to this at the moment. The format of the session, we're going to have some slides at the beginning, and then we have some questions that I'm going to be asking the panel. And after that, it's really over to you guys. So any of the questions that you have, please pop them in the chat. Please upvote them as we're going along, and we'll draw from those questions after we've finished kind of our list of questions. Please be respectful to everyone. There is kind of no judgment on anything that anybody is doing within this area at the moment, and we really want a solution-focused approach to how we approach this. It's being recorded, so you can watch it back afterwards, and if you could give us some feedback, that would be great to help us tailor the session for the future. And stay tuned right to the very end, even if your tummy's rumbling, to get your secret code to earn those extra points to get to the top of the leaderboard. So with me today, I have Jennifer Benson. Jennifer is a company founder and an independent SLT, and she is a company founder of Jennifer Benson Speech and Language Therapy Limited. We've also got Helen Vernon. Helen is the head of service for speech and language therapy, stroke and neuro rehab, and the professional lead for speech and language therapy at East Lancashire Hospitals NHS Trust. And if there were extra points for the world's longest title today, she would get them and be top of the leaderboard. And then finally, we've got Lisa Hope, who is an independent speech and language therapist working at Jennifer Benson Speech and Language Therapy Limited. So I'd like you to all have your phones ready, if that's okay. We're going to do a quick Mentimeter poll. So we've got a few questions that I'm going to ask just to take a bit of a temperature gauge to see how people are feeling around adult communication therapy, around waiting lists. So if you've grabbed your phone, take a picture of that. I'll give you just a couple of seconds to get that in case your phone is in another room. I will say I'm not quite sure how many people we have in this session, but there is a limit of 50 on this quiz. So I didn't want to have too many and us be waiting a long time. So we can move on quite quickly with it. So we'll get ready for our first question. I'll just give it a minute to update it. Sorry, just give me 2 minutes. I'm just going to stop sharing for 2 minutes and then come back in. Apologies, there was a plugin for to use Mentimeter in PowerPoint, and it just doesn't seem to be working on the other one that I was doing. But now, Okay, so our first question was, within your organization, do you feel eating, drinking, and swallowing referrals are prioritized over communication referrals? So this was a theme that some people were coming to, so it's really interesting to just get that temperature gauge of it. So we've got quite a large majority of people saying that yes, it is. So we're at 21 at the minute, with only a couple of people saying no, it isn't. Okay. Our next question. Okay. Do you feel you're able to offer the right type, apologies, of communication intervention that will meet the needs of the service user? So, very few people saying always, some saying mostly, which is encouraging. Quite a large amount of people saying sometimes, and only a couple saying never. Okay, thank you. So, our next question is, are you able to offer enough intervention to meet the service user goals? So this is really, can you give them the intervention that they need for as long as they need it for? So not just, an X amount of time as determined by the service, but can you continue to offer it to meet the service user's goals? Okay, okay, so we've got a little bit of a split there. Still, again, a large number saying no, that they can't do that. Um, I'd say about a quarter of people saying yes, they can, and a few people that are unsure about that. So, our next question is, are you able to maintain your competencies in the clinical area of adult communication? So, this can be whether you feel that you're saving enough service users, you're getting enough CPD opportunities, you're getting enough training to still feel competent to work with adult service users with communication difficulties. So this is good. We've got a good number of people saying yes, they're able to maintain those competencies. But then we've got some people who aren't so sure and are saying no, they're not able to maintain those. Thank you. Okay. So some of you might have noticed the recent NHS waiting list figures that have come out, and we wanted to know for you, how big a concern are adult communication waiting times? With one being you have no concerns at all, and 10 being this is your biggest concern at work. This is the thing that worries you the most in your working life. Okay. So we've had about half people vote. We're at around seven at the minute, 7 out of 10. So we are going more towards that higher end of level of concern um, within this area. And this is the last kind of Mentimeter slide. And this is really, we want to hear from you. So I'm going to take all that information from the poll back within the organisation. But what is it that you really need from RCSLT to do to support you within this area? So this should be a free text box. You can just put down whatever you want, whether that be, more lobbying of the government, more CPD opportunities, more SENS, whatever you feel you can do we can do to support you. Great. So influencing, keeping that retention up, management support, safer staffing figures. That's something that's been coming up a lot recently. Funding, health outcomes, the difference that we make there, funding more adult communication services, evidence synthesis, better communication training courses to access via RCSLT. I will say there are some great courses that we have on the CPD site. So if you haven't seen those, please do go and have a look at them, especially the kind of introduction to and walkthroughs. So I'll let you, you can continue to um, enter onto that slide, or you can put them in the chat function as well. I didn't want it all to be doom and gloom today. So I've asked my colleague Catherine, who works on the route to the RCSLT online outcome tool, to say what difference does it make in adults? What difference are we making at the minute? And she just pulled off a couple of stats for me. So almost 80% of people with aphasia, so this is not just kind of post-stroke aphasia, this is all the progressive aphasias as well, are improving in at least one area of impairment activity, participation, well-being, and carer well-being subsequent to speech and language therapy intervention. So you are making a clinically significant improvement to people with aphasia as measured by the TOMS. We looked at dysarthria as well. So for dysarthria, are we making a difference? And yes, we are. Again, nearly 80%, so 78.7% are improving in at least one area across those 5 domains in terms of intervention after they've seen a speech and language therapist. And that's clinically significant improvement across that. And remember, this covers all dysarthrias. So this is dysarthria associated with acquired dysarthrias, but also progressive as well. So that's a really strong starting point for us. Next, we're going to move to our panel discussion. And for ease to be able to kind of see everyone, I'm just going to stop sharing. Okay, so briefly, I'd like each of the panelists just to say kind of why they're here today with us, what they want to support you with today. So Jen, would you like to go first?
Yeah, thank you, Kathleen, and thanks to everybody who's joined us, particularly at this late hour of a really long day. We appreciate your support. So I think for me, this topic has kind of come about from the feedback that we're getting from our patients, clients, whatever we want to call them tonight. That really there's a feeling that communication therapy is suffering, I think, and that people are sitting on waiting lists for a really long time, that people are not getting enough communication therapy, and sometimes as well that the quality of that therapy is not as they would want it to be. So people are perhaps being given an iPad to complete their own therapy, but not having very much contact with a therapist. And we're getting a lot of this feedback. So it's not just one sort of location that's giving us that feedback. It's all of the locations that we touch on within the business. And I think just really trying to highlight that we are the specialists, we are the experts in communication. And although we fully acknowledge the importance of the work that we're doing in dysphagia, really just wanting to have that discussion about where the balance comes, where the dysphagia has really taken over some of the work that we do to the detriment of people with communication difficulties, and really just to start that conversation about how do we address the concerns that people are bringing to us in that area.
That's great. Thank you, Jen. Helen, would you like to tell us why you're here today?
Hi, thank you, Kathleen. Yeah, I mean, we've had some really interesting discussions between ourselves when we've been preparing for today, and I think as a manager and as a leader of quite a large speech and language therapy service, I've got some real concerns about competency, about exposure to communication therapy, and really what that looks like in terms of future proofing those specialist communication skills for our profession moving forward. So that's, it's really, really important to me as a dysphagia specialist, as I was in my clinical life, that actually we we really keep those extremely important skills, because I think for most of us, that's why we went into the profession in the first place, went in as speech and language therapists, to be experts in communication, to enable our patients to have a better quality of life, and to really advocate for those patients with communication difficulties. So I want to see those skills develop, grow. I want us to see the breadth of research that we have within this field grow as well. And I want to ensure that as a profession, we're not losing sight of that in the modern NHS and in the NHS that we work and live in and are treated by, in terms of all its pressures that we're facing at the moment.
That's great. Thank you, Helen. And Lisa, would you like to tell us why you're here today?
Yeah, for me, it's been a bit more. So I've recently moved across into independent practice, having worked in the NHS for a very long time. And I did feel when I was in the NHS, it was very heavily a dysphagia caseload. And although I did have some skills in communication, I didn't feel competent with that. And having moved to more independent practice, I'm able to do a lot more communication input. And I feel I've just managed to grow my skills and kind of reconnect with the therapist I trained to be back when I qualified. And I think it's nice just to reflect and think about all those important skills that we still have.
That's great. Thank you, Lisa. So my first question is towards Helen. So, Helen, some of the difficulties may be at a strategic level, for example, adequate funding of services. What are the challenges from a strategic perspective within the NHS, and what can be done to improve the situation?
Thank you, Kathleen. I think, we are working in a complex system within the NHS that's really pressurised at the moment. And I work in an area where we've got one of the busiest A&Es in the country. And I think the pressure to support patient flow through the hospital, to enable appropriate discharges, to prevent patients from coming into hospital, particularly with things like aspiration pneumonia, with the complexities that are associated with dysphagia, it is becoming more and more of a focus, really. I think we've always had that focus, but it's becoming even more within this modern NHS. So I think we've got speech and language therapy services that are often competing now for resources against acute services, high profile services that are maybe able to demonstrate the impact in terms of patient outcomes, not better than us, but with a more tangible impact on the things that are driving our systems at the moment, such as patient flow, keeping patients out of hospital. So I think we've got a real challenge in terms of that. I think at a strategic level, we've also got things happening within the NHS like workforce shortages. So we know we've not got enough speech and language therapists coming out of university. We also know that even if we have got them coming out, we haven't necessarily got the posts for them. So we've got things like frozen posts. We've got cost improvement plans that we're having to make as well. So we're looking at cutting services. So I think we've got, at a strategic level, we've got some real challenges. We've also got rising referrals. Everywhere I go, the acuity of patients are changing. They're becoming more poorly. They've got more needs. That therefore impacts on the amount of time that a speech and language therapist is required to give to that patient. So it could double, whereas sort of 5 years ago it could have been an hour, but now it's 2 hours. So we've therefore got increasing activity just against that single patient. So I think we've got issues around that as well. I think there are many things though that at a strategic level we need to do with speech and language therapy services. So it's really important that we've got strong leadership, at a professional leadership level, also amongst the sort of AHP, chief AHP level as well, just having those key relationships with those key people within our organisations as well. I think it's very important to engage the ICB. So within my region, we're very engaged with the ICB, with our chief AHP. We're constantly taking issues to him, but also looking at pathway redesign as well at a strategic ICS level, rather than just thinking, well, as this single provider organisation, we can't deliver that, so that's it. We're thinking outside the box much more as a provider collaborative, I think is going to be even more important in this current climate where we've got increased demand, same capacity, and also these drivers around flow. So I think there's a lot of things that we can do, but collaboration, again, that lovely word, is going to be really key across ICSs as well as within providers.
That's great. Thank you, Helen. My next question is for Lisa. Lisa, some people may have the resources to supplement NHS therapy with private therapy. How can both SLTs work together to ensure they get the best outcomes for the service user?
I think working together is fantastic, and I've had the opportunity to do that quite a few times. And some of the best advantages is the sharing of resources. So there's things that the NHS therapists will bring in and things that I will bring in. And with sharing, we're collaborating and working on it together. One example of this is the NHS have really good use of iPads, which they're loaning out to people for increased access to therapy. And a chap that I've been working with has been given one of these, and he was feeling a bit negative about it and a little bit unsure. And I was able to come in and really reassure him and push that and encourage that. So I think that working together and them hearing it from two different sources has been fantastic. And he's really got on board with it now, and he's doing it absolutely loads and making lots of progress with that. Really increased his amount of therapy that he can get. And because I've been working with him for such a long time, I'd built up a really good rapport with him. So it's good to really encourage that two-way working. And another good thing that we can do when we work together is we can either work on a shared goal, again, coming at it from two different angles, or we can work on two different goals side by side. So one may be taking more of a focus on one area and me taking a focus on another area. Because communication is so huge. How fantastic if we can kind of be working on two areas side by side. It's just going to enhance and support each approach, each therapeutic outcome. And it just gives that opportunity for more sharing of ideas, sharing of everything really, all for the goal of that patient. And it increases that intensity as well, which we all know is so important. And all it takes really is a bit of communication between myself and the NHS therapist. So it's quite an easy thing to do for such a huge improved outcome.
That's great. Thank you, Lisa. And just to reiterate, we're in the position now that we have waiting lists within some independent practices, which is quite novel, and we've not had that before. And the allocation of kind of resources becomes even more appropriate then across both organisations. I'm going to go to Helen again now. So Helen, with increasing demand on NHS services, are there any opportunities to improve how we are working?
Yeah, I think for me, we need to look at the long-term plan around this. So the NH long-term plan demonstrates 3 key shifts, doesn't it? And I think as a profession, we need to get on board with these 3 key shifts. So one's prevention. So I think we've had a talk today on speech and language therapy in the prevention public health agenda, and I think we need to really get on board in terms of how we can influence that prevention agenda around keeping patients out of hospital, and how that links into the wider priorities of the NHS as well. Because I think if we can make ourselves front and centre and important in that patient's journey, either keeping them out of hospital or getting them out of hospital much more quickly as well, I think that will be significant for us. I think the digital agenda is massive, and I think there's so much that we as speech and language therapists can do around the digital agenda. So that second key shift is around analog to digital. So I think for us, in certain areas, we've led the way around digital solutions. So certainly in my area, we've got a virtual care home pathway. We've got our voice pathway is pretty much virtual now. So that enables us to see more patients. We've also got group therapy. So we're doing a lot more group therapy, some of which is online, some of which is in person. We've also got neuro rehab online service within my region as well, where that's a group therapy delivering higher dose intensity therapy for patients, which we know really makes a difference. Use of AI. So again, we're looking at ambient voice technology to support with some of our clinical note writing, some of our report writing, being as efficient as possible and getting involved in these agendas, national and local agendas, is going to be really important for us to do. And I think the other thing for me is around MDT working. So that community shift. So really being very embedded in MDT working. So again, in our region, we're looking at doing things differently in terms of care homes. So we've got a number of AHPs going into care homes, a number of assistant practitioners, assistant workforce. How can we do things a little bit differently? How can we utilise, upskill? We talk about capabilities, not just competencies, but capabilities. So how can we ensure that staff from outside of speech and language therapy actually have some of our capabilities and can deliver some of those more basic skills within an environment that and doesn't always need a qualified speech and language therapist to go into. So making sure that we're fully embedded into those MDT teams. And I think the other thing that I would say is we've really got to get very clear about our demand and capacity modelling based on our clear clinical pathways, and get really hot on that as speech and language therapists to make sure that we're demonstrating our worth, but we're also demonstrating gaps, and we're also demonstrating what we can add, where we can add value into clinical pathways.
Absolutely. I definitely think there's a lot of data behind it that we need to jump on and utilise. And I know the NHS England waiting times that come out, community adult waiting time, so it doesn't separate EDS and communication, over the past few years is up by 41%. So that's a huge amount that you're be expected to see more and more. So we need to think about differently, but also how we can adequately resource and say how much resource we need. That's what we really need to do. Going to move across to Jen now. So Jen, where does the intensity of interventions and evidence-based practice fit into communication therapy?
It's kind of the $1 million question, isn't it, really? And I think it's almost the $1 million question that we don't have enough answers for. And it was really great to hear about some of the research work that was going on particularly from Claire, who I was listening to this morning, looking at some of those issues. And I think we really know that the quality of the data that's out there in the research is not sufficient at the moment to support, I guess, the sense feeling of where our intensity comes in. It makes sense, doesn't it, that if we do more therapy, people get better, and people get better more quickly. So I think it's how that gets captured within the research and the evidence base is really critical for us all to be very aware of, and great to hear that work that's been going on this morning. I think there are so many little bits within that topic. I think the first thing that we really have to think about is neuroplasticity with so many of our clients. So if we're talking about our acquired brain injury clients, and I include stroke very, very much within that remit, that basic underlying principle of neurorehabilitation that we're working on with those clients relies on that neuroplasticity. We know from research that goes beyond speech therapy research that neuroplasticity is absolutely key to that recovery. We know that neuroplasticity occurs when there's lots of repetition, there's lots of input, there's lots of high intensity of the dosage of that communication therapy. And the really lovely point that came out from Claire's talk this morning was about making that functional therapy and making that therapy bespoke and personal to that individual who you're working with. And there's a lovely term in the literature, which is ecological validity, which is what is my favourite at the moment. I love a bit of ecological validity, and it means working on what you should be working on in the place you should be working on it in. And I really think that's what makes the difference. And I think that allows us to take our evidence base as we know it, take all of the things that we learned when we trained and all of the things that we've learned since, and bring them together with our creativity to produce some really, really top quality functional therapy for the clients that we work with. And I think it really is taking that evidence base and taking that creativity and bringing them together to make sure that we can produce that therapy. Intensity is going to be a challenge whichever service you work in. So there may be some people who are sitting there thinking, oh, you private therapists can do whatever you like and it's all great and you can see people as many times as you like. And it doesn't really work like that. We do have the luxury where people have the funds, or where our funding has come from a different source, to be able to work with people for a really long period of time and to be able to give some of that higher dose intensity. But I think even as when with backing from insurance companies, etc., we still can't always meet that dosage that was being suggested by Claire this morning of around 20 hours per week of communication therapy. That's a huge amount of therapy. But imagine what a difference we could make if we could get anywhere near providing that level of therapy to our clients. And I think the other thing just to bring into that is thinking about lifelong rehab, and that's something that we've been talking about a lot recently within the ABI field. And lifelong rehab acknowledges, I think, that people will, with an ABI, will have communication needs right through their life. So there will be points where that intensity of therapy is the key and the important part, and that might be within that, it might be within the early stages after their ABI, it might be once they go home and they're in community. And I would argue that that is probably where they need that intensity the most, and where we can also make the biggest difference to people in terms of impairment, but also in terms of function and quality of life. And I think then people being able to access therapy services as their communication needs change throughout their lives is also really important. So we have people on our caseload who are between 7 and 10 years post-stroke or post-brain injury, traumatic brain injury, and have come back into services for some therapy because their communication needs have changed, and our communication needs change as we progress through life. So to close doors and to expect people not to access therapy at different points of their life is not realistic. And again, that's a challenge to services to be able to offer that lifelong rehab. But hopefully that's a conversation that we can start to have. And some of those system changes and being able to pull in that data, pull in the research data, and also that evidence-based data that comes from collecting stats such as the Root tool, hopefully that all comes together so that we can start to support some of those changes and just get that communication therapy back on the table. We're really good at communication therapy. We should be doing more communication therapy. We're the only ones that our patients' clients have got to do that for them. So we need to not lose it. That's really, really important to me.
Absolutely. And it was interesting in the kind of the health and inequalities and prevention earlier when we're talking about we're living longer, but are we living well for longer? And our service users can live with this condition, this change for the rest of their lives, and at different points that will very much change. Thank you, Jen. I'm going to move to Helen now, and I think Jen touched on it a bit that people with communication impairments, by the nature of their impairment, may have difficulties accessing services. So, how do we ensure that they can access communication therapy?
Yeah, thank you. I mean, yes, Jen touched on the strategic commissioning there as well. And I think before we even get to accessing the services, it's making sure the services are available to them, isn't it? And I think that's very much around ensuring that the speech and language therapy requirements of our patients are part of commissioning priorities. And that's, as speech and language therapy leaders within our region, we take that very seriously in terms of advocating for the needs of those patients. So I think that's really important, and actually highlighting the link between communication difficulties and health inequalities, which obviously since COVID has been a huge government national agenda. So I think that's really important, just in terms of making sure we've got the services that patients can actually then access. And I think there's been a lot around limiting services in terms of time. This in the stroke world that I very much work in. the new guidance is all about clinical need instead of commissioning 6 months of an integrated community stroke model, for example. So I think we've really got to shift away from that traditional model of time limited services into what the patients clinically need. And I think you're right, Jen, we should have services where patients can dip in and out. If I need counselling when I'm 80, and I needed it when I was 40, I'd still be able to access that. And why aren't we allowing our patients to do that? I think that's a really important point that Jen brought out there. So I think in terms of accessing services, I think it's about simplifying referral processes. So as I talk to colleagues from across the country, we've got some really complex referral processes, even down to making GPs jump through numbers of hoops in order to sort of help us with that triage process. So I think we've really got to think of ourselves as part of an MDT. So enabling our colleagues to be able to refer into our services on behalf of patients with communication difficulties, I think is really important. And so thinking as operational managers, how we make sure that those processes are streamlined. I think patients need multiple entry points for referral into speech and language therapy services as well. So through our neighbourhood teams, through community hubs, through the GP. So I think we need to make sure that our services are as accessible as possible in terms of having those multiple entry points. I think having a toolkit for assessment and treatment as well, so having hybrid approaches for assessment and treatment and not making assumptions that the older generation won't want to have a video assessment triage call, because certainly in my world, in terms of neuro rehab online service, we've blown those assumptions out of the water. We've got many of our older generation patients who are very, very happy to connect with us in a digital way. And I think the other thing for us is really utilising the third sector to support with access to our services as well. So using much more of our charitable partners, enabling them to support patients to get access to services where they can have the communication therapy that they need as well. Thank you.
Great, thanks, Helen. And I completely agree. There's a really interesting poster as well, if people get the chance to see it, from Leeds Beckett around them using their university clinic and supporting service users there with all types of difficulties. Jen, I'm going to go to you next. So we might have some SLTs on the call who might be feeling a little bit de-skilled. They might have lost that passion for communication intervention. It might be due to service pressures, for example, to see more people with EDS difficulties. What advice would you give them to kind of reignite that passion, set those flames alight again, and how can they reskill in a cost-effective way?
Oh, that's a really good question. And I think the first part of that it makes me sad to think that anybody would have lost their passion for communication therapy who's a speech and language therapist. So I think that again brings us back to the title of the topic that we're talking about, that whole back to our roots. And I think Helen touched on earlier, I imagine that we all went into our profession to want to work with people with communication difficulties, and possibly didn't even know anything about swallowing difficulties when we set out on that journey to become speech and language therapists. And again, I definitely do not put down the good work that goes on with swallowing and EDS. But yeah, let's get that passion back. Let's remember what we're good at, where our skills lie. And as I said, we are the only ones that have those skills to the extent that we do. And I think when you work not solely in communication, but predominantly in communication, you really see the ripple and the impact that working with people with communication difficulties and improving their communication has. So it's communication goes through all aspects of our life. It's just central to everything that we do. So just to look at a tiny portion of that, within that MDT focus, having that speech and language therapy and working on that communication improves that person's access to their rehab within that whole MDT focus. If you haven't got good communication as that central core of your your therapy, your rehab, you're not going to be able to access every area of your rehab. You're not going to get back to work if that's a possibility for you. You're not going to maintain relationships with your friends and your family. You're not going to, oh, I don't know. I've got a really nasty case ongoing at the moment with a lady whose mental capacity is being questioned at a really quite a high level. And if we didn't have input with her communication to support her with those mental capacity assessments, what happens to people? What happens to people if we're not there doing that communication work? So I think reignite your passion by thinking about what it is that we do and what it is that we're able to achieve when we do it well. And I think there are so many resources out there to support with redeveloping those skills. And I think, Kathleen, you touched on a lot of the RCSLT resources that are there as a starting point. But I think for me, what it really boils down to is just having that basic skill of listening to what it is someone wants to achieve. And I think going and talking to people and listening to people and finding out what their goals are. And Lisa always talks about taxi therapy, which which sums it up beautifully. So one of our ladies who is in her 90s and had really quite a big stroke, but has had a phenomenal recovery. She wanted to be able to get in a taxi. She wanted to go to Marks and Spencer's to do her shopping, have a cup of tea, and get in a taxi and come home. So Lisa went out in the taxi with her and achieved all of those things. How meaningful is that? It's great. That's the power of what we can achieve with communication therapy. We've got loads of examples like that. So I would say the most important thing is to kind of accept that you maybe don't feel 100% confident with things. Remember that passion and that skill that brought you to our profession and what a fabulous profession it is in the first place. Go out and talk to people and listen to people and think what it is you can do to support them to achieve their goals. And I think that's the most important part of it, really.
That's great. Thanks, Jen. And this is my official plug. We do have so much information on the website. It's almost impossible to find it all, whether that be our YouTube channel, which has got recordings of all the webinars that we've done, whether it be the CPD site that has got multiple kind of, how to do an aphasia assessment, how to do informal assessments, right the way through to our minor grants. So they're open at the moment. You can apply for up to £800 to support your CPD. Closing date is, I think, mid-February for that, so there's plenty of time to get in. And that could be for a course, it could be a module, it could be textbooks, it could be to fund accommodation for a course that you want to go to. So please do look at our learning section of our website. And if you think there are gaps there, please let us know. info@rcslt.org. Let us know what we're missing, what we need to develop. I'm going to move back to Helen now. So how do you think supervision can support SLTs to develop their communication skills?
Thank you. I think supervision's key, isn't it, for so many things, and getting the structure right is so important. I think for me, it's not just about supervision, and one of the questions that we asked in Mentimeter was about competencies. So it's really about the exposure that staff are having as well to patients with communication difficulties, and how much time they're able to spend in working on impairment and functional based goals. And I think that is, we've said this all throughout this discussion, haven't we? That is becoming increasingly a challenge. Whether that's on a ward or in a community environment, when we're looking at things, I mean, certainly as a manager, I'm looking at things like job planning at the moment, and giving staff targets for how many contacts they've got to see because of the demand on our services at the moment. And I think that's the environment that we're working in. So I think it's twofold, isn't it? One, it's ensuring that actually as a manager myself, we are giving realistic targets in terms of the numbers of patients that can be seen in a day, to give them a high quality service, So it's about that, and then it's about, yes, making sure that we are keeping those really important specialist skills in communication within our services. But also, again, for me, it's about collaboration. So it's about outside of our provider, who's got those skills. So, um, so we've had a Band 5 peer network. So I would hope that part of that is about upskilling our Band 5s. But doing that as a provider collaborative. So it's not just about one provider organisation, but it's about Band 5s from across our ICS coming together, joining together, to share those skills, to develop those skills from other more senior specialists who are a bit more experienced. So I think supervision's key. I think it's not got to be done just in one provider organisation. I think we have got to get better at collaborating across our ICSs. Leaders need speech and language therapy leaders need to collaborate together to ensure that that supervision's happening not just in our own organisations but across our systems as well.
Great. Thank you, Helen. The last questions for Lisa before we go to the questions that have been submitted this evening. So Lisa and I had a conversation and you tell me about these kind of myths that you hear quite a lot around communication input. Could you share a few of them with us?
Yeah, I know we're a bit tight on time, so I'm probably just going to hammer home the most important one is this idea that someone has reached their rehab potential. I think that's the biggest myth out there, that they've got no further rehab potential or they've reached their potential. And I know that's not true because I've not reached my potential in life and things that I want to do. So how can our patients have possibly reached their potential? And I think we just get stuck in this cycle of the therapy's either stopped working, and so we kind of assume that's because we've got stuck in that myth of they've reached their potential, they have no further potential to improve. But actually, maybe we just need a different approach. We need to look at things different, change it up a little bit. There's always something else we can do. I don't believe that it exists that someone has reached their potential, and I think if we can stamp out that myth, I would be very, very happy.
Absolutely, that's great. Thank you, Lisa. So the first question, so this came across a couple of questions, was around should we be kind of ring fencing? Should we have more kind of specialist, protected, dedicated communication posts within adult speech and language therapy to help protect job satisfaction, retention, to kind of get away from that being swamped with dysphagia? I'm just wondering if any of you want to come in on that.
Well, I would think that that would be an absolute great thing to do. Helen might disagree with me. I don't know. But I think ring fencing communication posts would be absolutely fantastic, because I think it feels as though the career path of an adult speech and language therapist very often is that you qualify, you start off in your Band 5 post, you're doing communication and it's all great. And then you're expected to do your dysphagia training, you do your dysphagia training, and then all of a sudden your communication input just disappears. And I guess that may not be the case for everybody, but certainly that is what I'm observing and have observed for very many years. So I think it almost feels as though dysphagia then becomes the superior thing to do, because you progress through your banding and you progress into different posts, but you have to have dysphagia to do that. And therefore it's not only is it prioritized clinically, but it's also seen as it's seen as your progress, it's seen as your promotion to be working in dysphagia. But really, why shouldn't we be experts in communication? That's what we set out to do. So if ring fencing is a way to achieve that, then I would be all for that. I think that would be a great idea.
Right, thank you. The next question is around where dysphagia is being prioritised over communication. And some services saying, you've got such a backlog of communication, we'll just stop referrals. We won't accept them onto the waiting list anymore. So how do we show managers, service providers, commissioners that there is value in communication intervention?
Do you want me to answer that?
Yep, come on in, Helen.
Sorry, I froze earlier. I think, this is going to sound really, it might sound a little bit crazy, but it's hearts and minds. So I've just, before I came on this call, we're trying to get a business case through for neuro rehab online as a service. And I was very surprised by our chief AHP. He said, I wasn't surprised by this, but he said, put the patient story at the beginning. He said, because we've got to win hearts and minds. And I think to me, and I mean, that's really encouraging to me that as our chief AHP is saying that, we have to the patients need to tell the story. We know how absolutely devastating it is for a patient to lose their ability to express themselves. 'Cause that's their whole personality, isn't it? Um, so I think it is hearts and minds. It's putting the patient story front and center, doing it really innovatively. I mean, we do lots of things with AI. We do lots of videos. We really make sure that patient story is front and center, so that the ICB and our colleagues within the ICB are seeing the impact for patients. They're saying, this service that we've got here is significantly changed my life. It's also offering me peer support, So I think it is winning over the hearts and minds of the ICB. It's not being afraid to do that. It's putting the patient story front and center. Also the staff experience. So as a therapist, this is what this means for me, and this is my job satisfaction. This is why I train to it, and this is the impact, train for it, and this is the impact on patients. So patient story, front and center, hearts and minds of the ICB. The tear jerkers, make them cry, is my biggest takeaway for that.
Great, thank you, Helen. And I think we've done some work with an organisation recently, and the way we phrased it to the therapist was, you wouldn't do an intervention with a client without ensuring they're making an informed decision. Are the commissioners and the ICBs making an informed decision about funding your service? Do they know the risks and the benefits for communication of the funding model that they're providing? Really drum it home and then make them cry with it. Sorry, Helen, did you want to come in?
No, I was just going to say, and it's the system. This is really hard to quantify, but it's the system costs. So we know there's a psychological cost to having a communication impairment. It's a carer burden. There are, and I think we need to get better in our profession, but wider in looking at that economic impact wider on the system as a whole, because again, that speaks the ICB's language in terms of long-term cost savings for the ICS for health and social care as well.
Absolutely. And there is, I'm not sure if it was one of the sessions today or tomorrow, around a scope and review of the economic impact of speech and language therapy. I'd definitely say go to that one, have a look at it.
Can I just say as well,
yeah,
Kathleen,
sorry.
if people are
Yeah.
if people aren't aware of the UKBIF report, Right to Rehab, that came out, I think it was dated in May this year. And of course, that's about therapies and access generally to rehab. But that talks about the impact of lack of provision on to clients and to their families and to their well-being, and to a tune of 91.5 billion pounds. So that one speaks for itself, I think.
Absolutely, it makes a huge difference, and we do need to get better in research at measuring that economic difference that it makes to someone. We had a request just to add these slides back up again, so take a screenshot, whatever you want to do. And we had a question around root data to demonstrate which interventions lead to improvement in the different domains. At the minute, it's not sensitive enough to pick that up. However, we are looking at, should we be recording specific interventions within that? So, for example, if you are doing intensive kind of interaction therapy, if you're doing an intensive voice therapy, what difference does that make? So we're looking at kind of how we can evolve to look at those kind of individual things. I'm going to phrase this to Lisa, and then we're going to go really quickly. Actually, I don't think we've got time for it. I'm really, really sorry, but I just wanted to say thank you so much to our speakers today. You have been absolutely amazing. We will try and answer all the questions that everyone has shared on the chat. We hope we've given you some food for thought. Thank you so much.